Welcome everyone to today's meeting for the BPRG's subgroup for diversity, outreach, and inclusion. My name is Mike Alpert. For those of you who haven't met me, I have worked with Anne for years. We were co-therapists for the MAPS clinical trial of MDMA-assisted psychotherapy. Super glad to be hosting this event. I actually went to Cambridge for my psychiatry residency, and I'm very excited to be having today's speakers, especially given Ben's ties with Cambridge. So today's event is going to be focused on really important issues that relate directly to our work with psychedelics. And this is particularly going to be, we're talking about issues related to healthcare access, differential access to treatment, health equity, and diversity within the mental health care system. And we have two fantastic experts on this to engage in dialogue with us around how some of these issues might apply to psychedelics. So Valeria Chambers is the peer support facilitator of Black Voices Pathways for Recovery, that's spelled with the number 4, and she's a mental health advocate and senior community researcher at the Health Equity Research Lab at the Cambridge Health Alliance. And our other guest speaker today, Ben Cook, is the director of the Health Equity Research Lab, the director of research within the Department of Psychiatry at Cambridge Health Alliance. He's also an associate professor in the psychiatry department at Harvard Med School. And his research interests are in improving methods for measuring disparities and applying these methods to understanding the mechanisms underlying mental health and substance abuse treatment disparities, the association between acculturation and mental health, and geographic differences in mental health service use disparities. So we have two people with a broad range of expertise in general mental health issues, and we, as a community interested in the research and clinical applications of psychedelics, can think today about how some of what they're saying might apply to our work. And hopefully we can engage in dialogue with the speakers today about how we can draw on their work and the broader field of healthcare equity research in order to improve the state of affairs with psychedelic clinical research, and also in the rollout of psychedelic medicines in legal settings. So to start off today, we're going to be getting into small groups. That'll be for about 20 minutes, and someone else will be taking care of the tech part of that. But I encourage you all to use the small groups really however you see fit. But some ideas, some food for thought would be to talk about your general thoughts, impressions of issues related to healthcare disparities, and also if you have any thoughts of where those kinds of issues are coming up in the field of psychedelics work. And we can think of these small group discussions as a chance to really have some in-depth conversations the way we might at our general meetings if we were in person, and also think about this as a chance to start generating some questions that you want to be bringing up with the speakers, or if there's any issues that really speak and resonate with you that you'll want to bring up for the Q&A. So thinking of these as little kind of incubators for that time. Really excited to hear what everybody has to say on this subject. And so maybe we can start moving towards the small groups, unless anyone else has anything they want to add or any other questions about today or the meeting before then. Or is there anyone else who wants to add anything?
Mike, no? I can just add a tech component. If anyone has any issues with the breakout rooms, they can just message me directly.
Okay, that's Sherry over there in the corner.
Yes.
Yeah. Okay, great. And great. Welcome. So yeah, so if you wouldn't mind doing the tech side of things and arranging the small group stuff, yeah, we can sort of move our way over there. And then around 3:30, we'll be moving back into the main dialogue space, and we can get started with the guest speakers.
Okay.
All right, welcome back, everybody. So I am thrilled to have our two speakers here with us today. I gave a brief introduction before, but just a quick reminder for those of you who just hopped on the phone call. We have two speakers joining us from the Health Equity Research Lab at the Cambridge Health Alliance. One of them is Valeria Chambers, the peer support facilitator of Black Voices Pathways for Recovery, and is a mental health advocate and senior community researcher at the Health Equity Research Lab. And we are also being joined by Ben Cook, who is the director of the Health Equity Research Lab and the director of research in the Department of Psychiatry at the Cambridge Health Alliance, and does a lot of work on measuring health disparities and understanding mechanisms underlying mental health and substance abuse treatment disparities. So welcome, Ben and Valeria, and we are all looking forward to hearing what you have to say. They're going to speak for about 40-45 minutes, and then there's definitely going to be a solid 15 plus minutes for Q&A and an additional time afterwards for more free-form discussion. So start thinking of your questions, and if they want, they might make their speech a bit more interactive or save the questions for the end, but we do have a chat going and we'll have plenty of time for questions. So thanks to both of our speakers, and we're looking forward to hearing your thoughts on the subject.
Thanks, Mike. Hi, everybody. Oh, I do see a share screen. Okay, so maybe I'll switch to slides. Thanks for that introduction, Mike. I'll talk a little bit more about the Health Equity Research Lab and what we do, but it's wonderful to be here. I think this effort that you all are working on is so important. There's such little armamentarium in some ways for mental health problems and substance use problems, and the work that you all are doing to expand that armamentarium is so important. Let me share my screen and see if we can get this going. Can you all see that? Okay, great. All right, well, so I'm going to present some statistics. I'm a health services researcher, and I'm also been trained in community-based participatory research, and really have focused a lot on health equity and mental health services disparities and substance use treatment disparities. And I'll kind of give a broad overview of what I mean by that, what I mean by disparities. But I also wanted to spend some time today talking about this idea of ex-novation. We spent a lot of time looking at the black box warning on antidepressants. And I think it may be relevant for thinking about innovation for disseminating psychedelic research. It might be a stretch, but I was trying to pull something together that of the studies that we've done that I thought might be more relevant to this group that's trying to innovate a new type of treatment. All right, so this is the Health Equity Research Lab. We really do try and put health equity at the center of the research that we do. I'm thrilled that Valeria is here sharing the time with me. She's a key part of our lab in bringing the community voice to the research. And you'll hear more from her about the patient-provider interaction and her thoughts about psychedelic research and the potential for that. We do a number of things. I won't go through all of that, but we do use big data analytics to try and prevent negative social health and mental health outcomes among racial and ethnic minority populations. We do quite a bit of mentorship. We try and identify mechanisms, and one way we do that is to look at Medicaid and Medicare insurance, as well as nationally representative data sets, and that's where I'll be presenting some results today. And then we intervene to reduce disparities, and as I was telling the breakout group, we do some evaluation of really innovative things that are happening at Cambridge Health Alliance, where I'm based. And those innovative interventions are around mindfulness interventions, there's behavioral integrated care, and some other substance use treatment, group opioid-based interventions. Undergirding all of this is patient and family engagement, and we really do want patient, family, community engagement to guide our research questions. Okay, so let me give you a little perspective on this. This is a Kamara Jones cartoon that she has in one of her articles. It's getting older now, from 2009. I think Kamara Jones does a wonderful job in taking very complex concepts and breaking them down into very understandable ways. And she uses this analogy of a cliff to identify how disparities arise. So you see this stick figure. This stick figure is in quite a bit of trouble. He's about to fall over this cliff, and now has fallen over the cliff. And you can extend the analogy to think about social determinants of health as the things that are pushing you further away from the cliff. And there's a fence, and you can think of that as primary prevention. There's a net that will catch you when you fall off the cliff, and you can think of that as safety net programs and secondary prevention. And then there's medical care and tertiary prevention. So often when we are talking about healthcare, we're down here where the ambulance is, and thinking about what happens once you enter the healthcare system. And this graphic really helps us to think about health and health disparities from a much wider lens, and helps us to situate, where are we talking about the disparity? What is the disparity that we're interested in? Are we up on the cliff and thinking about all of the ways in which the allostatic load of vulnerabilities and discrimination and racism affect our health? Or are we down where the ambulance is and thinking about what's happening once we're in treatment? So then disparities start to arise in that there are some groups of individuals who are further away from the cliff. They have primary prevention in place. The safety net is well established. And when they do get to treatment, then that treatment is quality and according to the needs of the folks that make it there. And then there's another group, the vulnerable group, the minority group, the group that's having much more difficulty. And they have no safety net to catch them. They have no fence. Primary prevention is lacking. Their social determinants of health push them towards the cliff. And then when they get to the hospital, they don't get quality of care. So you can start to fill in the things that we're talking about here. And quality of care and treatment outcomes are some things at the ambulance, safety net hospitals, insurance, and the ways in which that protects you from financial vulnerability is key in the safety net, and thinking about that. Public health interventions, addiction prevention, primary care checkups, early detection. And then the things that are probably most important in many ways to determining disparities in health. And we're thinking about racial and ethnic disparities in health, gender minority, sexual and gender minority disparities in health, language discrimination, those kinds of things, are these social determinants of health. And I would argue that, the criminal justice, housing, and hospital segregation are a key component here. A lot of folks talk about structural racism and what that is. I mean, to contextualize this, think about 350 years of our country's history intentionally working to keep a lower caste of individuals in that lower caste through segregation in the criminal justice system, segregation in the housing, segregation in the hospital, and an intentional dehumanization of Black individuals. That's 350 years. And then in around the 60s, you start to see desegregation of hospitals, mostly opened up because of the Medicare program. But you have this legacy of the centuries of intentional segregation and policies. So it really has become the air we breathe. And someone in my group mentioned how difficult it seems that maybe they're cynical about what we can do with health equity. But I get that, because the uphill battle is really against 350 years of intentional segregation policies, especially for African Americans, to keep them in that lower caste. And other racial and ethnic minorities have faced some of those same segregation policies, including Chinese in the ways that they've been excluded, but many other racial and ethnic minority groups as well. but not nearly to the extent, and I want to make that clear, as African Americans and the ways that they've faced segregation and discrimination over the last 400 plus years. Okay, so I'm gonna switch gears a lot, and I'm going to talk about what happens and where are the disparities. Now we're at the ambulance, maybe we're at the safety net somewhere, but thinking about psychotropic medications. And I'm hoping that a little bit of a review of our studies on psychotropic medications and racial and ethnic disparities in psychotropic medications might have some salience for this group and how you all are thinking about innovating and using psychedelic research and applying that these new, incredibly innovative and promising interventions and spreading that equally, or spreading that in an equitable way, or reaching racial and ethnic minority communities in a way so that you aren't just exacerbating disparities with a new and promising, innovative new intervention. And I gotta tell you, most of these slides are gonna be daunting. So what we're up against is difficult. And I think you're right to be concerned about the fact that these innovations may not be equitably disseminated. So let's start with this. Black individuals, it's a little hard. Let me see, I can just move my thing here. Okay, so this graph shows you any past year adult psychotropic medication use. And what you can see that this is the general adult population in the United States. So I'm using a community-based sample. These are the folks that are, this is a household survey. It's not the individuals that are in treatment only. This is a community sample. Think of opening up all the phone books and random digit dialing everyone in the country. 20% of white adults have used some type of adult psychotropic medication use in the last year. And then you look at the huge 2-to-1 disparity to Blacks, more than that for Hispanic populations, and more than that for Asian adults. So almost 3-to-1 or 4-to-1 disparities in terms of ever using a psychotropic medication. Now, so those are just raw statistics, and there's a lot underneath that, and we can unpack that. But one thing, a number of studies have shown that Black and Latino primary care patients have found medications for depression treatment, for example, less acceptable, and that might help to explain that. That might be on on average, Black and Latino primary care patients find medications less acceptable. A study that I worked on really closely with Valeria showed that, in fact, when you look at community-based samples and not just in primary care samples, there's actually not that much of a difference between preferences for medication versus talk therapy for treatment of depression. But then we went on to try and understand discrimination. And it turns out that there's a significant percentage of Black and Latino individuals who have experienced a lot of discrimination in the healthcare system. And for them, they actually prefer medication more. So it's kind of an unexpected result in some ways, but maybe not if you are concerned about being re-traumatized in talk therapy. But it's kind of flipped on its head what a lot of people have thought, is that Blacks and Latinos are not accessing psychotropic medications because they don't want it. They have a lot of fear about psychotropic medications. And I think that continues, but what we found when we really dug in qualitative research, and I left the link there at the bottom, was that what's so important is the trust with the provider. It's really the provider that's going to be the one that's going to show that they have your back, the one that's going to say, you know, I think maybe you should have this medication. And if there's a trusting relationship and a patient-provider alliance, then Black and Latino individuals, even with experiences of discrimination, are going to be willing to take psychotropic meds. All right, so that's a very general overview. What's happening in the country with psychotropic medication use? If you did this for any mental health care use for adults and kids, you'd find 2-to-1 disparities. If you did this for substance use treatment, you'd find very few people are getting any substance use treatment at all. This is where we spend a lot of our time. Less than half of people who need mental health treatment get any mental health treatment at all. Only about 5 to 10% of individuals with substance use disorder get any treatment at all. And so that focus on the community and bringing people who are outside of the healthcare system into the healthcare system is what we think is kind of the most important and salient. All right, so let me shift gears again and think about the black box warnings. We've done a number of papers, and I'll present 3 or 4 of them, that have looked at the black box warning to see if they might have some relevance to the idea of disseminating this new psychedelic therapies that have such promise. Again, I'm going to think about the black box warning as ex-novation. There's kind of a warning that needs to be disseminated. In the case of psychedelic treatments, that's an innovation that's being disseminated, but I think there are a lot of parallels there. So 2003, 2004, there were kind of a number of announcements that said black box antidepressants increase the risk of suicide for 12 to 17-year-olds. A black box warning was put on a number of antidepressants except for fluoxetine. And what you see is a pretty drastic drop. There was a large increase in that pre-period of antidepressant use. And then right after the FDA black box warning, you saw a real decline in antidepressant use. What you've seen later on, and now this is increasing, you can keep taking these lines up. And now we're in the late teens, and in 2020, antidepressant use is actually much higher than this pre. But you did see that that FDA warning had a significant impact on that. And what do we know about racial and ethnic minorities? And here's kind of the point, the take-home point on the black box warning that I wanted to say, is that whites responded to the black box warning. White individuals aged 12 to 17 had far less antidepressant use after the black box warning, which hit, you can think about that hitting here. You can see a pretty drastic decline over time there. It was relatively flat. In other work that we've done, we found no change in slope, a small change in level, maybe an increase for Black and Latino youth. So there's clearly a difference in how antidepressant use changed after the black box warning. And you could also say that that's a differential diffusion of the black box warning, where it really was salient in the white community, but not in the Black and Latino community. This is something showing another study that we did showing something similar in a Medicaid population that showed the decline in treatment, depression treatment following the FDA antidepressant warnings was actually all treatment. So there was a big decline, not just in psychotropic medications, and you can see kind of here's the pre-slope, the black box warning hits. Here's what the slope would have done for white individuals. And here's what the slope actually did for white individuals. And same with Black and Latino, you can see the slope would have kept continuing to rise, but it came down. The key here is that this outcome isn't antidepressants, it's treatment. It's any outpatient treatment at all. So a response to the black box warning was not to decrease antidepressant use, it was that, but it was also to decrease outpatient treatment overall. So primary care providers pulled back from treating teenagers with depression. A number of providers decided there was too much risk involved and just didn't provide any treatment at all after the black box warning. So again, this one says the risk information diffused less rapidly to prescribers or caregivers of minorities, so you don't see this drastic change that you do in the white population. And then you also see that the black box warning led to decreases in depression treatment visits, not just decreases in antidepressants. And much of the antidepressant decrease was due to the fact that they just weren't getting any more treatment. So if you start from where I was before, a lot of people are outside of the healthcare system. That black box warning actually put more people out of the healthcare system, at least for this age group. One more thing to mention is you start to wonder, well, why is that? What's driving that? And so we there's a lot of individual behavior that's driving it. There's family behavior, there's caregivers in the case of teens. But we wanted to know about providers, and what do we know about providers in the way that they drove that decrease for whites, the fairly steady path for Black and Latinos, and the disparity there, and how this disparity actually in an ironic or troubling way, actually that disparity reduced after the black box warning. And what we found is that that slower diffusion of the FDA warning that I was mentioning was driven in large part by providers treating racial and ethnic minority youth. So there's significant provider level variation in prescribing patterns. We were able to use multi-level models that showed that, that providers were driving the prescribing patterns just as much, if not more, as individual decisions. And the differential effect of the black box warning by race ethnicity was also driven by providers. We also found that those providers with a large proportion of racial and ethnic minority patients reacted more slowly to the black box warning. I want to focus on that last part. I think that one ends up being key to the work that you all are trying to do. There is a lot of evidence that shows that providers who have a majority racial and ethnic minority patients deliver evidence-based practices less. There's evidence that shows that providers that treat predominantly racial and ethnic minority patients are less likely to be influenced by new and emerging external scientific evidence. Okay, so that work that we had done on the black box warning, we found this differential reaction to the black box warning, and we found that the reason why Black and Latino slopes remained somewhat constant was because the providers that were treating Black and Latino individuals weren't reacting to the FDA black box warning. And this follows upon a lot of other research that shows that providers that are working with racial and ethnic minority patients don't use evidence-based practices, and they don't react to new risk information and emerging scientific evidence. Okay, so what does that all mean? So some of the takeaways that I think that I'd like to leave you with are: one, racial and ethnic minority individuals access mental health treatment. They fill psychotropic medications at less than half the rate of white individuals. You can do this by youth, by adults, by elderly, and you get similar results. It may reflect less acceptability for some of these treatments, but when you start asking folks who are outside of the healthcare system and those who have been in it but left the healthcare system, it really shows that there's trust in your provider matters. And when people feel discrimination in the patient-provider interaction, they'll leave care and they won't come back. When a patient decides whether or not to take a psychotropic medication, having the provider be there and having their back ends up being a huge part of why they'll take that medication or not. And then the other thing is, this black box warning may be a useful example of what might happen in the dissemination of psychedelic therapies. That it diffused more rapidly among the providers and caregivers of white patients than it did among caregivers and family members and providers of Black and Hispanic youth. And then warnings of antidepressant use led to less antidepressant use, but also wiped out a lot of outpatient psychotherapy, suggesting that providers will be reticent to provide any treatment at all when there is a great risk associated with the treatment. All right, so that's some of the work that we're doing that I wanted to share today, and I want to pass it over to Valeria, who will give you another perspective on similar things.
Thank you, Ben. Let's see, I'm going to try to share my screen. This is my, let's see. There we go. All right. Everyone see it?
Yeah, that's great.
Yay. It's my maiden voyage here on Zoom. Anyway, it's so great to be here. I'm Valeria Chambers. I'm a certified peer specialist, which means that I use my lived experience of mental health trauma or addictions to connect with others in recovery. I work with Ben, as he said, the senior community researcher, and also I consult with a Center of Excellence for Psychosocial and Systemic Research and the Bureau of Substance Abuse Services, helping to create a mental health module for their recovery coach folks. Began working with Ben's group a few years, I guess it's now like 6 years ago or so. And we had the good fortune to work together on a Black Voices project. So I want to talk about what I've been learning from this group that I created some 15 years ago. I heard so much about people's unhappiness at best, sometimes even traumatic experiences within the mental health system. The project we worked on was Blacks addressing mental health and healing through comparative effectiveness research. What was so great about this work was that we had a whole year to work together, so that we had community members and researchers working together to really understand what people find helpful and what they don't find helpful, and why. As I listened over the years, I realized basically what I was hearing can fall into 3 possible avenues: what attracts, what keeps, and what doesn't. What is it that attracts us as people seeking treatment, seeking help for mental health conditions, for PTSD or trauma, for substance use disorders? People want to feel easeful. They want to feel relaxed as much as possible. They don't want to feel stressed out in this new relationship with the provider. People said that they wanted to feel welcomed in a way that's culturally congruent, in a way that's familiar and put them at ease. To be taken seriously, to be listened to be respected, to feel some value, that what you're learning from them is important. People also said they want to see other folks in the environment that look like them, look and sound like them, whether it be providers, the front desk, but also people sitting in the waiting room. They wanted to see people that looked like them in positions of authority, but also they wanted to see people in the same role and status as themselves. Even the environment of a place means so much. Is the place fixed up and nice and clean, or is it run down and shabby? Are there pieces of art that reflect one's culture and other cultures? People really wanted acknowledgement of past wrongs, acknowledgement of the power imbalances. And they wanted to hear from researchers and their providers how you are going to make it right. How, even in whatever sphere you are in, how can you use your privilege, your connections to chip away at injustice? What keeps us engaged and coming back for more? Huge thing is enough time. These 15-minute appointments, how in the world can you get to know anyone in 15 minutes? Having time to actually explain, to share our point of view and where we've come from. You can't do that in 15 minutes. People said they wanted to hear ongoing feedback about that their needs, their concerns, their wishes, their fears were being heard, noticed, and addressed. People really want to know when you care. If you don't care, they don't want to be there. But you have to demonstrate that you care. You know, it may seem obvious because you wouldn't be in these professions if you didn't care, but you have to find a way to make that evident to people. Because of so much trauma historically and present day, people often fear ulterior motives and that providers do not have their best interests, that researchers don't have their best interests at heart. We want to see that you too can learn, grow, and model vulnerability. We don't want to feel like we're the only ones doing this hard work and like bearing our souls. We want to hear a little bit about your life and your struggles and your concerns and what you're working on for yourself. What absolutely doesn't keep us and may even just leave us screaming and running from the room? Feeling unheard and unseen. Feeling like who I am in my totality as a Black woman is not even visible. To be colorblind is an insult, a microaggression. We want to be seen. We want to be heard. We want to be celebrated, as we all are celebrated for who we are. Feeling disrespected, even inadvertently. Feeling lied to, or that you're not being transparent about what's really going on. Another huge thing is feeling embarrassed or ashamed or stupid. I use the word stupid intentionally because it's that negative self-talk, you know, especially in new environments when talking about really painful and intimate details of our lives, feeling ashamed or embarrassed or feeling like we've done everything wrong or we're such a mess or we should have known better or blah, 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 blah. So it really helps when you can acknowledge that and help us see that, you know, it's not that, you know, we are just horrible people or done something wrong, etc. So many voices that we hear from society that actually cause people to go underground further and further and not want to speak about mental health issues, not want to speak about their addictions. Finally, people wanted to know that they have a choice. When you've been pushed against the wall and you feel you have no out, where can you go? You know, people want to feel like they have input into what's going to happen to them. And even if they can't dictate what happens, take the time to explain it, to break it down, to make sure people have time to answer all of their questions. And it's going to take more than 15 minutes. You see, there is so much to each of us. We have so many cultural and racial identities. Racism, classism, sexism, colonialism, heterosexism, ableism, and so many more. And for BIPOC communities especially, this means just oppression after oppression after oppression pounded upon each other. It's scary at best and quite terrifying to be in situations where on so many different levels you have to address living as a person of color, living as a minority in this culture, living with conditions for which the society severely stigmatizes you, discriminates against you. And that means we have our own internalized stigma on so many levels. Internalized racism. Trauma-informed and trauma-sensitive practices are absolutely crucial because the effects of multiple trauma really, really add up. In the peer support movement, we assume that every single person in recovery has experienced trauma of one sort or another at one time or another. These effects compound fear, hopelessness, feelings of isolation, helplessness. They make it hard to trust ourselves and hard to trust you. All of this compounds painful life experiences that make it very difficult to move on, to connect. And then we come into PTSD, symptoms of trauma, fight, flight, freeze, or fawn responses that, of course, make the connections even more difficult. What can you do to help? Well, self-determination is so important to us. We want to feel like we can make a choice and that we can be included in the decision-making, at least where possible. When we can do that, you see an increase in empowerment, an increase in hope, an increase in buy-in and engagement, and an increase in follow-through. We want you to understand that we are the expert eyewitnesses on ourselves and our lives. We want to know that you can utilize that and help us make those choices that will help facilitate our healing. We hope that you can listen and learn from us and our experiences, because then you can believe that we will be more likely to listen, learn, and trust you. It's got to be a two-way street. It has to be, in some ways, mutual. If there's any way to, even within the dynamic of provider and patient, or therapist and client, find some way to connect to our common humanity so that we don't feel this huge power differential that just kind of makes you feel so small, so insignificant, so stupid. Two of our favorite phrases are nothing about us without us. It's research. That's evidence-based practices. That's policy development. Our voices are to be heard at every single level. Why? Because help that doesn't help isn't really help. Last week, I talked with Black Voices virtual group about coming here today. They were really, really interested. Boy, we talked about a whole hour. Group is 2 hours long, and people had a lot to say. I have to say, probably not too positive. People had a lot of fears. They had a lot of concern. You know, I guess everyone went straight to, you know, the 60s and, you know, hearing people tripping on LSD and things like that. So they were really surprised to learn that this is something that can be done as part of psychotherapy. They had questions like, well, what if I get addicted? What if I actually have an addictive personality and don't know it, and this brings it out? What if the therapist doesn't understand my trauma history and the layers there, and I become triggered and I wake up at 2 o'clock in the morning? Who is going to be there for me? How can I make sure that I'm going to be supported through this? Another person said, well, how are they going to manage a person who just signs up to get high, you know, or just, you know, decides to do this for fun? One person took a very philosophical kind of point of view, and she said, you know, I can't hope anymore. I've been struggling for all of my adult and teenage life with 24/7 suicidality and depression and PTSD. I've gotten to the point where just hearing about something new, you know, I can't even entertain it. Because at what point do I just need to say, you know what? I'm just going to have to live. I have to live with this for the rest of my life. I've tried 1 billion medications, 1 billion treatments. Things work maybe for a little while, and then they stop. Maybe this is just something I have to accept. Similarly, another person said, what exactly are they looking for? What is this therapy? Like, what's the ideal outcome? What exactly are you hoping for? Because it seems like it could go either way. What's the ideal? There were a couple of people who said, no way, Jose. Nothing could make me, no amount of money, nothing could make me participate in a research study like this. It's just too scary and too unknown. There were 3 people who were very interesting. One is a clinician finishing up on her internship, and one person saw, I guess, a show on 60 Minutes about mushrooms and psychedelics, and was really impressed. And she was like, hey, I will be there tomorrow. So people had a lot to say, and they thought if anything like this came in their direction, they would want to have lots of time to have all their 1,000 plus 1 questions answered. And they wanted to know who's behind this? Who are the researchers? They want to know what your story is, what drives you. What are your fears around this? What are your hopes? It's been great talking with you all. Thanks so much.
Thank you so much, Ben and Valeria, for both of your thorough, thought-provoking presentations. I know I have a bunch of questions that I would love to ask both of you, but I also want to give the opportunity to everybody else in the crowd to ask questions as well. So with that said, let me turn this over to the rest of the crowd here, and we have Ben and Valeria at least for the next 15 minutes or so to answer any questions you're coming up with. And feel free to either ask them directly, or if you feel more comfortable, you're welcome to put them into the chat and someone can read them out loud for you.
I have a question, Mike. Hello, both Ben and Valeria. Thank you for your presentations. They're both amazing, and I found them to both be highly, highly relevant to sort of where we are here with psychedelic medicine and sort of the course that it's going forward on. My question is for Ben. I really thought your presentation was super applicable to kind of point out ominously rather where this might be headed in terms of diffusion of information and access to care. My question is, what are the ways that primary care providers can be engaged that will make them primary care providers that are treating predominantly minority or disparity involved patients? What are the ways that they can be engaged in a way that sort of is a bulwark against that effect of them not providing evidence-based care, or ways that they can be encouraged to adopt new innovations if possible generally, and then if there are ways more specifically locally that you know through your work?
Yeah, that's a $1 million question for a lot of different types of therapies and one, and for mental health treatment and substance use treatment more generally. You know, I think there are structural things that have to be lifted in order to spend the time that Valeria was talking about. The primary care visit that I go to, it feels like a blink of an eye. I got a million things that I want to say that I think are relevant to my health, and that's me. But I feel just shoved out of there. You know, my father is getting cancer treatment, and the oncologist came in talk about a clinical trial. He never even sat down. He had one foot out the door. Mm. So there are patient-provider interactions that need time, and they need providers to care a little bit more, like what Valeria was saying, and they need to understand how to ask the right questions. So there's a project that Valeria and I were a part of called the Right Question Project by Maggie Alegria, and it was training patients to go in with questions that they had for their provider, so they wouldn't be bulldozed by a provider who was ready to shove them out of there. And it turned out that it was very good for the self-efficacy of the patient, but outcomes didn't improve because providers were saying, wait a second, all of a sudden these patients of mine are asking all of these questions, and I feel threatened by that. I have a way that I do things, and this is disrupting that, and I'm falling behind on time. And so what she did was then go on to train providers on being better at being willing to hear and accept those questions and respond to those questions. And I think that helped improve things when they did the kind of 2x2 trial that trained both providers and patients. But in the end, they were hamstrung by the fact that they really only had 15 minutes. So I think the time that it takes for a primary care visit is far too short. And for a lot of folks that struggle with mental health, substance use treatment, that's not long enough. For individuals who have experienced a lot of discrimination, it's not even close to near enough. In fact, there will be times where a lot of patients won't bring it up because of the fear that they're going to be re-traumatized in the telling of the story, and they're not sure that their provider is ready for it. Mm-hmm. On the other hand, Valeria's group has told us that somebody did get up the courage to talk about all of the experiences that they had as a child growing up, facing intergenerational conflict due to structured racism over generations. And at the end, the provider said, I don't know if I'm the right person for you. I don't know that I'm well trained to help you with those issues. And maybe you should consider someone else. Imagine that after waiting 6 months to get that visit, if it was an intake for a psychiatrist or a psychologist, for example. So I don't know, there's a lot of things here. There are structural things to expand the visit. There are ways to train providers to do a better job of listening to the questions. There are better ways of training patients to ask better questions. There are going to be times where you can't train everything to everyone, and you might need a group of specialists. There may be groups that are really good at doing therapy that's culturally relevant, has humility. And in those cases where you really need that, you bring in a specialist, just like you would have a liaison. For psychiatry, for primary care, why not have a liaison for someone who is really good at understanding where people are coming from. They look like them, as Valeria is saying. The patient doesn't have to spend 60 minutes trying to help them understand what they've been going through. They'll get it right away. So those are some of the solutions to get at this general problem of how we fix some of this, all of these disparities in primary care. Now, I don't know how relevant that is to innovating and to creating new innovations and to having primary care providers be the ones who are kind of the gatekeepers and referring people so they feel comfortable. That seems like yet another level of having to take some more time to build trust, to say exactly what is this new psychedelic therapy, how safe is it? So it's gonna, I started this with saying this is an uphill battle. I think it is. I think if we do the default things, this is going to exacerbate disparities because it's going to go to the well-heeled white folks who know how to handle the health services system, who don't have experiences with discrimination that they have to go through or deal with in the primary care or specialist system. It will require a complete shift to say, we want to put this new exciting therapy into communities of color that are low income, that are typically left behind. And you start with that, put all the resources into that first and make that the first thing that you go after. And then let the ones that'll come in slowly be the second thing. But that's almost never the way it's done. And the pressures, the financial pressures isn't going to lend to that either. So it's going to be an uphill battle. And it really would require a complete reorientation of the rollout of the trials and the dissemination of this.
Thank you. That was a great answer. Yeah, maybe we need more psychedelic. We'll need more psychedelic liaisons and specialists.
Yeah. Well, thank you so much, Benoit and Ben, for your question and answer there. Going off of that, I actually have a question for Valeria, based on what we were just talking about, and Valeria, what you were saying in your conversation, which is how it really sounds like among the people who you spoke with about this work, there's a lot of hesitation and mistrust about getting involved in psychedelics work, particularly in psychedelics research, which is completely understandable given the centuries that we've seen of discrimination against African Americans, particularly in the medical setting and in the research community, as well as with all of the racial legacy of the drug war. So, given that we're currently at a moment in psychedelics research where we in the research community recognize that it's a serious, serious problem if our clinical trials don't reflect the diversity of the population at large, we're actively trying to find ways of engaging with minority communities in order to do the things you're talking about, building trust, recruiting patients and clinicians of color to this work, and if not getting quite there, at least having the dialogue around this work as a first step. What are some steps that we as psychedelic clinicians and researchers can be taking in order to get that dialogue going within the communities in the Boston area that are underrepresented in our
Thanks, Michael. Well, you know, I think the main thing is first making connections with the gatekeepers in communities, the leaders that are working at the grassroots level, community organizers. There are some wonderful organizations that I learned about doing the research with Ben's group. Little known, you know, very small groups that are really utilizing the community's gifts to create healing spaces. So I would suggest ways in which to just begin having conversations with those people. And even before kind of putting forth your agenda, spending time to hear from them what's going on in their communities, what the concerns are, what the needs are. Begin to have a dialogue so that you can form what you present in such a way that it's more likely to be heard and received. I think that's all I can think of right now.
Thank you so much.
Mm-hmm.
Can I say something to Anne?
Yes.
Thank you so much, Ben and Valeria, for your description of so many of the hurdles we're trying to think about and see what we can do to help. So one thing, Valeria, if you have ideas of communities where we could come and speak, any of us who are involved in the research, I'd like to make an offer. There are a lot of really involved people here in the Boston area. And if that's something you'd like to talk about away from here, please let us know if you think groups are interested.
Great, thank you.
Thank you.
Hello, can you hear me?
Yes.
Hey, this is Mackenzie. Thank you to Ben and Valeria for coming to talk about these really systemic things that we have going on just in general in mental health care. And Valeria and Ben, we've talked a little bit, or I've given a little bit of my anecdote about how, psychedelics really are, they seem like there's this renaissance and things going on, but there are so many other things here around just other innovations, as Ben had alluded to. And I think that there is an opportunity to actually be more community engaged in psychedelics, but those have to come not necessarily from clinicians. And I think that that's part of where the criminal justice perspective comes into the criminalization of drugs and maybe even at large. So could you speak a little bit, maybe Ben, about how there have been maybe just drug policy influences some of, and maybe even Valeria, like drug policy, the criminalization of drugs may have some stigma on the way that people approach care just in general, like outside of research, just the usage and uptake of Schedule 1 through 3 type drugs?
Yeah, sure. I'll take a crack at that. I'd like to hear what Valeria thinks about the relationship between drug policy and stigma. And Mike, I think you brought that up, the ways that in which the drug war has impacted racial and ethnic minorities. You know, I think there's a feeling of what the hell happening in a lot of racial and ethnic minority communities now that marijuana is being legalized, right? So many families have been torn apart because of marijuana possession, and now it's a bazillion-dollar industry, and it's legal in so many states. You start with that. I think you start with a feeling of real resentment in the ways in which the drug war has played out in the United States. And, you know, I think there's been a lot written about that. Carl is one of the guys who I think is really good talking about his own experience and growing up in Miami and going from someone who was in the drug scene, got out of the drug scene, and then now does research in substance use treatment and the ways in which some people get wrapped up into dependence and some people don't, and the kind of arbitrary ways in which that occurs. But, you know, on the criminal justice side, having worked a lot with police, especially in Cambridge and the Middlesex Sheriff's Office, there is increasing emphasis on diversion for youth especially, but also adults who are having substance use issues and trying to get them into mental health courts and substance use courts, and not just throwing them in jail for possession or use. And then we're doing a number of projects that for people who are being sectioned because of their overdose or because of their suicidality are being involuntarily put into inpatient treatment. And whether there's an opportunity there for policing and ED docs and community health outreach workers to identify folks who are really in need of substance use treatment and mental health treatment. So I think I don't think I have an answer for exactly how that's going to work, but bringing in the criminal justice piece of this and their enthusiasm for doing diversion projects. Police are tired of picking up the same people every week and taking them to the ED or taking them to Middlesex. They want to find a way to keep people off the street and keep from overdosing all the time. So they're invested partners, but they come from a historical context that is, I'm good at locking people up and controlling the safety of the situation. So that's a different language that you have to speak in order to bring criminal justice folks into this conversation. But there's an opening there because they're tired of locking people up because that's what they do all the time. When I give trainings to them, they say 60% of my calls are about mental health problems and substance use treatment. And I don't feel like I'm equipped at all to do anything about it. I know how to do safety and I know how to control a situation that's become dangerous. I'm not a therapist or a counselor. So all that to say, I don't know, there's a lot of stigma that's carrying over, but there's also an opportunity to involve the Cambridge Police Department, other police departments, the Middlesex Sheriff's Office. They're looking for new opportunities for ways where they aren't just incarcerating people with substance use problems and mental health problems. But I'd love to hear also what you think, Valeria. You have some good thoughts about that question too.
Well, I think there's so many layers to it. And I think for many people, you know, thinking about pharmaceuticals, many people have so many fears based on historical record, as well as things that they have been put on or tried where they had severe side effects or tons of weight gain or, you know, blood level changes where they had to go to the ED. So I think the whole concept is very complex for Black communities, for people of color.
Yeah, and I just have to say, right, so if you run into the dichotomy, which we pretty much do with things like, you know, illicit buprenorphine and methadone use, is like, it's only medical if it's provided in the service area in which it is deemed like necessary, right? So we run into this situation where people understand, they get educated on psilocybin and mushrooms and stuff, and they know that it's going to cost them a lot of money. They can't get it with their healthcare insurance, and then they go use it illicitly, get caught with that. It's criminalized because it's not being delivered in a medically, quote, necessary like environment. We run into this like double standard of like criminalization for using a drug that is therapeutic, but not necessarily in a deemed therapeutic way with a licensed professional. We continue to exacerbate just historical drug policy that criminalizes people's desire to heal. And I don't know. So yeah, thank you.
Yeah, it's so frustrating. I think many people are really looking to this past year that we've been through, especially Black communities going through pandemic of COVID, but also pandemic of racism. Many people are looking to their roots, looking to Africa, looking to indigenous traditions and healings, and really seeking ways to connect on a personal, spiritual, emotional level. And so for that reason, there may be more interest in natural drugs, plant medicines. But again, it's, you know, how to make that available within a system that is already so slanted.
Hi, Valeria. I was just had a thought about what your question or what you were just saying about those different ways to connect. And, you know, I really think about that training piece for the clinicians. And when you guys were giving when you all were giving your presentation, I was just thinking about, you know, how many, you know, clinical social workers, psychiatrists, and psychologists start their careers out working in low-income communities of color in their internships and practicums. And, you know, so most of the time, folks of color in these lower income communities are the training ground for professionals. And then, you know, as they get their experience, they move out of these communities and typically move into treating a white community. And I think that sort of framework sets up a lot of the dynamics that we see in the mental health system. And I think I think the opportunity for psychedelics is to reshape the role of the clinician as not as the one who's not the wisdom keeper, that the wisdom keeper is within, and that these medicines can really bring the wisdom keeper from inside to the external and more present in our lives. And I think that would really take some reshaping for the professionals to be in a place to see that, you know, because these are plant medicines, opposed to really complicated psychiatric medicines that have all kinds of complicated terminology. And I think it's really tapping into that. And, you know, if there's any model that we could think of to really, you know, kind of how do we embrace that in our field, because our professional identities are really just extensions of our ego that we need to let go of anyway. So I don't know if you guys have any comment on that.
I love that, the idea of getting in touch with the wisdom, the healer within. I think it's something that we have been increasingly distant from over the years, over the generations. We keep getting further and further and further away. So true.
Yeah, I'd agree. I think what you said is really powerful in terms of training and the ways in which the training system is set up on the backs in some ways of low-income racial and ethnic minority communities, so that therapists can go out and make a lot of money not treating private insurance, Medicaid insurance, but going out of pocket to very wealthy white folks. That happens at Cambridge Health Alliance every single year. We have a huge training program at Cambridge Health Alliance. Many of you may know it. And they're training folks in long-term psychotherapy that very few people can access because it's not covered for more than 8 sessions in Medicaid or even much commercial insurance. And so there are a lot of folks receiving training on individuals in long-term psychotherapy, and then they go out and they leave the safety net hospital insurance system to work on Newbury Street and open up a fat office. It's unconscionable in some ways, the ways in which resources are used to train residents and fellows. So one way around that is to train folks in stuff that insurance will cover. And I don't know if that's the answer either. I don't know that 8-session CBT is the thing that's going to solve all of our problems. But at least some of that will keep the training aligned with what insurance is paying for. But I think you mentioned a third road, which Valeria has talked about elegantly in other settings, which is there's a need for a parallel system, mental health care system. And for the way that Valeria has talked about it is peer support, and the ways in which peers are incredible at navigating not only the traditional healthcare system, but navigating the understanding of what is happening in racial and ethnic minority and low-income and vulnerable populations' lives in ways that the traditional healthcare system will never do a good job at. So then what is that parallel healthcare mentorship system that you create? How do you get that folded into an accountable care organization setup or some kind of managed care setup so that it can be reimbursed as well? And maybe that's where psychedelic therapy, which will require way more than an 8-session, 30-minute CBT, could hook onto, is that parallel track. We've talked about that a little bit with certified peer specialists and other peer support, and thinking about that being a parallel track, and maybe that's a potential third option. But it's an incredible point what you said about, and you said it much more succinctly than I've ever heard it, about the ways that we train residents and fellows to then go on and provide psychotherapy for different populations.
Thank you so much for that question and also for that answer, Ben. Going off of that, I'd like to flip it a little bit. We're talking about how in the current training system, a lot of the psychology trainees and residents learn modalities of treatment and become quite familiar with approaches that we can use in the training setting, like long-term psychotherapy, that just are not reimbursed at competitive rates by public sector insurance. Many people go through training programs, become enamored of these forms of treatment, go to the public sector as attendings or as full-fledged psychologists, find that there just isn't the financial reimbursement to do that kind of work, and then leave for the private sector. But missing from the piece in talking about the reform there is, the fact that a lot of these longer term treatments just are able to be having a lot more effect than an 8-session CBT. And the reason many people leave is that they want to be offering care that they see really works for their patients. So with psychedelics in particular, we have an opportunity to do what we're hoping for in the system in general, which is to reform how mental health care treatment is reimbursed in order to incentivize more providers to stay in the public system and also to offer care that's actually going to be really effective. For MAPS, for example, they're looking at long-term cost-effective analyses that are showing that the very labor-intensive treatment that we offer does break even after 3 years and saves $100,000 per patient after 30 years after doing a very intensive course of treatment. So my question is, how is it that we can potentially use this moment in the psychedelics research and in mental health care in general in order to try and do reform of the system itself, to make the system pay for treatments that have been shown with evidence to be quite effective, but that just currently are not being reimbursed, and that people are, as individuals, throwing up their hands and leaving the system altogether rather than offering what they see as subpar treatment?
Mm-hmm. Yeah, that's a great question, Mike. So I think the move towards global payments, value-based payments, accountable care organizations where the output is not graded on the number of visits, but on health outcomes and improvements in function and improvements in the reduction of symptoms, then that starts to open the door to types of therapies, types of peer support, teams of outreach workers that are working in unison with social workers and psychologists and psychotherapists and psychiatrists in ways that will improve outcomes. And that will be the kind of gold standard, is can you improve outcomes after a year, not can you increase the number of visits. The problem is that the value-based payment, those models are behind. Right now, they're often, what they mean by value is, did they reduce the dollars that were spent in year 2 compared to year 1? And if your timeline is 3 years, forget about 30 years, then that's not going to work, right? You need a 1-year return on investment. And often what that means in managed care companies is we enrolled this person in a managed care company, and then we found ways to keep them out of treatment, and so we saved some money. So you want to figure out another way to incentivize, to push the healthcare systems to do a better job in what they mean by value, saying that we have to reduce symptoms, we have to get folks back to functioning and employment and living their lives better. But that's a long road to hoe on the system side in order to align incentives with that. But if you can show that this psychedelic treatment is moving the needle and improving those outcomes while not costing as much, I think that is a way to do it. And the accountable care organizations is, again, a kind of toehold into that large reimbursement system, which is a behemoth and a giant cruise liner to turn. But there's a foot in the door there now that people are starting to think about value-based payment and aligning goals towards health outcomes as opposed to dollars or number of visits. I don't know if that's exactly what you were asking, Mike, or Valeria, if you had other thoughts about that. But.
Yeah, that was definitely getting to my question, and I think pointing out how short-sighted a lot of these ACO models are. is a really important point to keep in mind as we're thinking about these very labor-intensive, very expensive treatments that within a span of 3 to 5 years do have a significant amount of cost savings because they're so effective, but require an upfront cost that, because we don't have a universal healthcare system and the cost of healthcare is so fragmented, there just aren't those incentives in place right now. And I'm curious, Valeria, if you have any thoughts as well, given what you were saying about 15-minute appointments, just not cutting it, but yet being so cost effective.
Right. Well, that's one thing that we've been working on the advocacy level, because I think there's so many ways in which a peer support role can be utilized. For instance, in Boston, virtually every clinic and hospital has 4 or 5, 6 month waiting list for a psychotherapist. And that's a place where peer support specialists could be utilized to at least kind of walk with that person as they wait it out. Because, you know, sometimes it can take so much to finally pick up the phone and then to find that you have to wait. Who knows what can happen in that time? And that's an area where peer support specialists, recovery coaches could really be utilized.
You know, there are examples too of like Sovaldi is kind of the textbook example that a lot of health policy classes use. It's $70,000, but it takes care of your hepatitis, right? So thinking about the models that are out there that that Medicare is willing to pay and Medicaid is willing to pay in a number of states, and how to, you know, that's a recommendation, as you might think about the ways in which could a psychedelic therapy be packaged in such a way so that it can be successful in getting reimbursement in the same way as Sovaldi or something like that has.
Yeah, I really appreciate that point, because when we're talking about the costs involved, it's also worth noting, again, just the amount of stigma and the second-class status that mental health care has in the system, where the numbers that we use when we talk about an expensive treatment versus an inexpensive one are fractions of the cost of standard of care for basically any other life-threatening illness. You take something like these hepatitis medications that cost $70,000 a dose, or for the course of treatment. For a course of treatment with the MDMA-assisted psychotherapy that we're working with, we're looking at about $20,000 or so. And yet, in mental health terms, that's seen as outrageously expensive, while in any other specialty, $20,000 would be hardly anything. Now, I'm wondering if there's anybody else on the call who's got any other questions or comments that they want to be sharing with the group in the last couple of minutes. We've got about 5 minutes or so before we wrap up.
What I would like to advocate for is researchers to fold in an outcome piece of their study where they look at utilization of emergency room services, which tend to be some of the most costly services for the healthcare system. And so if they're looking at MDMA or psilocybin for reduction in suicidality or mental health hospitalizations, that's a really good place to make a case for funding these treatments before people get to a place of needing emergency room services. And so I think it might start with the research sector to consider whether or not these treatments are effective for saving the healthcare system money at the emergency level.
I would agree with that, but I would caution you that that is something that is available, and that's what I use a lot as an outcome measure is inpatient dollars and ED dollars. But the caution is that often preventive treatment means people get linked to the healthcare system and then they start using it. That's especially true for insurance. And we know from the Oregon health insurance experiment that once people got insurance, they started using the EDs more. But it's also somewhat true for mental health treatment, where once people start getting outpatient treatment and they get linked to a system that they've been completely removed from, then they start saying, oh, well, hospitalization might help me in this way that I didn't know about. My provider has told me about it. So you might start to see inpatient hospitalization, at least in the near run, and ED use. If you're connecting people into a system, you might see that go up. But it's a good idea and worth empirically to look at also. But I just wouldn't put all your cards into saying we're going to reduce thousands of dollars.
Wonderful, thank you. Does anyone else have any other questions?
I actually have one. I'm from Maine, and so Valeria, I'm interested in your training and how you got to be in the place you're in and how other people can train in the way that you have, or up in Maine, I think we could probably make good use of some people who have the kinds of credentials and experience that you have.
Yeah, sure. Yeah, I don't know whether Maine has a program yet. I remember I've had a few students come down from Maine to be certified in Massachusetts. But yeah, my the way I got here was quite unexpected. I had a lot happen to me and had severe depression. Spent a year in McLean. That was when they actually did therapy inpatient. And a wonderful women's program. When I got out, you know, I was told, look, you know, don't worry about going back to school or a job, just, you know, you're on Social Security disability. If you want, you can volunteer, but don't do anything stressful. Just basically stay home and rest and you know, keep up with your friends. And I was like, bet. I've had 8 hospitalizations, 3 series of ECT, like every medication class under the sun. I will do anything not to have to do that again. But as things happen, a friend called me up one day and she said, oh, you know, I'm working with this group. We're interviewing people in Dorchester and Mattapan, mostly Black community members that are doing day treatment programs. And we need someone to interview. We want to know from people what they feel is helping and what isn't. And she said, I remember you used to do that in graduate school. You know, we really need a 3rd researcher. And I was like, no work. No, I'm fine. She kept coming at me. Finally, I agreed. And I started really slow, a few hours a week. It turned into 18 years. And the last year was full-time. I think becoming certified, Massachusetts at the time did not have any certification or any peer support. I was the first group, 4 of us went to Georgia to learn the course and bring it back to Massachusetts. And at that time, I think only Hawaii and Georgia had peer specialists. And now many states throughout the country do. So it's usually done under the Department of Mental Health, or some states have it under the Department of Behavioral Health. Some people call it peer support specialist or peer supporters or a certified peer specialist. One of the problems we have is that there's no unified certification body for the entire country. And so each state kind of does its own thing. But in Massachusetts, we're working on insurance issues and how to become third-party billable for one-on-one peer support, because at this point, it's mostly inpatient units, emergency rooms, places like Bay Cove and VinFan and other accountable care organizations. There are some bridgers who work with people being discharged from state hospitals to kind of help them transition from the hospital into the community. Likewise, for folks who are leaving correction facilities into the community. So more and more, I think, we become recognized and utilized, but there's certainly a lot more room for us to do our work.
Thank you so much. And that's such a wonderful answer. And it would be great to hear about more people getting involved in such groups. And if we can see more resources like that spread throughout Massachusetts and also other states like up in Maine. And it's so great that all of you came out, that we can start forming these connections, hear the kinds of work that we're all involved in, and start thinking about how we can all be helping each other out to be working towards a common goal of justice, equity, diversity within the psychedelic research world and in healthcare in general. So I do want to be mindful of the time. It's currently 5 o'clock, which is when we said we'd wrap up. Thank you again for our speakers. And I hope that all of you will continue to stay involved with the BPRG. We have a meeting next month for the general group. And then the following month in April, we have my friend and colleague, Dr. Marco Ramos, who is a PhD historian and also a resident in psychiatry at Yale, who's going to be talking about the history of ayahuasca, and in particular, how that is a story in many ways of the history of whiteness as much as it is of the history of indigeneity. He has a very thought-provoking presentation on the subject, and it's really going to be a very exciting and stimulating discussion for all of us. So thanks again for coming to today's meeting, and I hope that you'll all continue to join us and stay involved in this work.
Thanks, everybody. Take care.
Thank you, everyone. It was a pleasure.
Thank you, Ben and Valeria.
Thank you so much. Wonderful.
And thank you.
Bye, everybody.
Thank you very
Thank
much.
you.
Thank you.
Thanks, Mike and Sherry.
Sure, my pleasure. Bye, Georgie.
Bye.